Welcome to the Neuroveda Podcast for Complex Health. We feature expert guests who dive into ancient and cutting-edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as they are about nature, culture, and politics. I'm Gillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health, in Seattle, Washington. And I'm excited about our guest today. Dr. Aaron Parker is a native Seattleite with detours in Oberlin, Ohio, and New York City. He worked in community-based brain injury rehab programs before pursuing his doctorate in clinical psychology. Dr. Parker is a licensed clinical psychologist in Washington State and has worked as an attending psychologist in the University of Washington Department of Rehabilitation Medicine at both Harborview Medical Center and UW Medical Center at Montlake, where he maintains a clinical faculty appointment. Dr. Parker has supervised psychology trainees, including UW Medicine residents and postdoc fellows, and has presented his research at national conferences. Dr. Parker also provides services to accident victims suffering from post-concussion syndrome and post-traumatic stress disorder through the Washington OSIC Concussion TBI Clinic. Dr. Parker's private practice has been in operations since 2019. He's an avid transit rider and bike commuter, and in his free time, he enjoys stereotypically Seattleite activities like hiking, craft beer, and pickleball. Oh my God, so Seattle. And he lives in the Beacon Hill neighborhood of Seattle with his spouse, his child, and his golden doodle.
Of course.
So welcome, Dr. Parker. We're so happy to have you. Thanks for being with us today.
Thank you so much. I'm really excited to be here.
And our conversation today is about pain reprocessing therapy. And I just want to tell a little bit of the backstory about why we have you here today, which is that a person very closely associated with our clinic had a son with 9 years of chronic abdominal pain. And in the end, it was the work that they did together with you that has made a big difference. And so I'm very curious to hear more about this and look at how it can kind of dovetail into the work that we are already doing for the patients at Neuroveda. So I'm so excited to talk about pain reprocessing therapy today.
Fantastic.
So what's the history and what is like the training like? What is pain reprocessing therapy?
Sure. Yeah, really broadly, pain reprocessing therapy, or PRT, as I'll probably call it today, it's a psychological treatment designed to help the brain unlearn chronic pain. And so it really focuses on retraining the brain to interpret sensations from the body as safe rather than threatening. And this is kind of particularly important and particularly effective when the pain appears to be what we call neuroplastic pain,
Mhm.
pain that persists even after an injury has healed or an illness has run its course, and when there's no clear kind of physical tissue damage driving the persistent chronic pain.
Can
Uh,
you talk a little bit? I mean, that's such a fascinating, like, physiologic loop. Like, what is happening there? Why do we get stuck like that? Why, when the tissue resolve, like the tissue inflammation resolves the pain, signals should stop signaling. Why do they get stuck in a loop? How does that happen?
Yeah, that's a great question. I'd probably need a PhD just in that to give the
Yes.
perfect answer, but I can touch on a couple of things that are, I think, pretty compelling and that I do often share with patients during this treatment.
Mhm.
And so one big factor is that the communication of kind of sensory signals from the body to the brain, a process we call interoception, we kind of think of it that the body is giving very specific information to the brain, but in actuality, it's sending a lot of kind of vague signals, and the brain is doing a lot of interpretation work around those signals to decide what they feel like and what they mean. And so, one of the ways that a process can get kind of stuck like this is the brain starts to expect sensations from a certain place in the body to be pain signals, and it starts to interpret them as pain signals, even when they might be a more neutral or ambiguous sensation in the way that they're transmitted upwards. Um, Another big factor in general is just uh, nervous system arousal. When our sympathetic nervous system, our fight or flight, is online, our brain is kind of wired to be expecting and looking for danger, and it's more likely to interpret any signals, including external or internal, but including the ones coming up from our body through interoception as danger signals. And pain is fundamentally a danger signal. The last kind of brief, really high level thing I'll say is just this idea of predictive processing, that our brain is not actually a blank canvas experiencing all of our senses, external and internal, from scratch with every moment that passes, but rather it's kind of modeling based on what has just happened and predicting what things are going to look and feel and sound like next based on that. And that predictive processing actually does a lot of work to skew or bias what we experience next. And so if the brain has been experiencing pain and has a sort of belief or construct that leads it to think there will be more pain, it starts to bias or warp our next sensory input to resemble what it expects in some fashion.
Amazing. Amazing. So, sometimes I've talked about it with patients like if you wake up every morning and you're horrified by this chronic pain, it's like a groundhog day of shock and horror. But if you come to terms with, I'm going to have pain today and I'm just going to get through it. I think that there's a survival instinct there. But then if the tissue heals and that pain is no longer triggered and your mind is still trying to do that survival piece of it's okay, it's going to be painful and I'm just going to get through it. There's a way that it helps you in some respects, and then there's a way that it continues to cause damage. So,
Yeah, that's absolutely right. There's often kind of a double-edged sword when we kind of develop these self-protective or coping mechanisms. They can start out adaptive and accidentally become maladaptive over time as circumstances change and our body changes.
yeah, our circumstances change or our body tries to stay the same.
Yeah.
I got this. I got this pain. It's not happening anymore. Okay, it's okay. I've got it.
Yeah. Yeah. And so you asked a little bit about kind of the history and the training
Hmm.
of PRT. And yeah, it is a relatively new treatment. In some important ways, it's descended from a variety of mind-body pain treatments that have been popularized over the last few decades. I think it certainly owes a debt to them. But it's also very much its own thing. Um, it draws heavily on research from the last couple of decades, some about chronic pain, some about kind of uh, abnormalities in the body and maybe how normal abnormalities in the body are, how findings on imaging, don't necessarily mean that someone must be in a certain amount of pain. And it also draws on really new research on neuroscience and how much we can do to rewire the brain over time. Um, and So it really broke out in September of 2021. So I guess that's really under 5 years ago as we're
Wow.
talking. That was the publication of their first kind of big landmark randomized controlled trial, the gold standard of Western medicine, got published in JAMA Psychiatry, a big medical journal. And that's on the Boulder back pain study. And so that was the first time they really took a big group of clinicians and a huge group of patients and went through it scientifically to say, what can we demonstrate are the outcomes of this treatment? And it was kind of a bombshell to the field because no one had really done anything like this before. Psychological standalone treatments for chronic pain were not that common. And when they did exist, they were really intended to maybe reduce anxiety and depression around the pain. And often the best ones could bring the average daily pain down by 1 or 2 points on a 0 to 10 pain scale, which is both very meaningful to the people who get that. Uh, and this treatment was different. This treatment was aiming to actually cure the chronic pain, to kind of get at the roots, or at least the fuel sources that sustain and keep the chronic pain going, and really change what's going on there to let the condition resolve. And they had a full cure rate, an average daily pain of 0 to 1 out of 10 of 66% of the participants in their initial study. And then
Oh my
about
God.
another two-thirds beyond that had significant improvements with only a few kind of non-responders. So that really shook things up, and it's been kind of an avalanche of PRT follow-up and training and all kinds of things since then.
Wow, that's fascinating. And so, um, that's amazing. Do you know how many patients were in that study by
It's
chance?
a great question. I would have to pull up
Okay. Yeah.
uh,
Yep.
the
Yep.
research to look. Yeah, but it was, it was an appropriate sample size to kind of make it into a major publication. And they've been
That's
doing some
amazing.
good follow-up research as well.
That is a very high response rate.
Yeah,
I mean, what are the response rates for SSRIs? Um, the antidepressants are something like 30 to 40%. I mean,
that's right. That's
that's
right.
tremendous.
And this is, yeah, 66% where the condition was basically fully resolved at the end of treatment.
Wow.
So,
Wow. Wow. And so, okay. Okay. Interest is peaked. Talk to us about, walk us through what it looks like. What is this therapy?
sure. So it certainly grabbed my attention. I went and found their training and signed up for it, and they do a nice job. They've got kind of a 4 week intensive training model where you kind of give 1 day a week to doing this work. You do, you know, lectures on the research, role plays, breakout small groups, kind of reading and listening to do outside to really nail down these concepts and how to apply them. And then putting it into practice has been interesting because it is a process-based treatment, not a protocol-based treatment, is what they call it, meaning it has certain core elements that need to be present. And there are maybe clinical indications for how long to spend on each one or how to order them for a given patient. But it's not cookie cutter. It's not a completely protocolized this before this before this. It's done in exactly, 8 sessions kind of treatment. Um, and so I think to some extent, each practitioner kind of has to find their own way and maybe find how to adapt it for the particular patient population they have. Um, it is commonly kind of described as a treatment that can be applied in something like 6 to 10 sessions, kind of hour-long psychotherapy sessions. I would caution everyone that is the most direct version of the treatment. So that's when there's no major complicating factors or kind of detours required. And there are plenty of things that could cause a detour, right? Additional time needed to go back for more medical workup to make sure the person is fully cleared medically to take this approach, or uh, other psychological factors like an untreated anxiety disorder of some kind would kind of need time and space for their own treatment before you can do the most direct version of PRT. But PRT itself, uh, I often find that when you can kind of really go straight through it with someone, it's a couple of sessions around education on the model, having the person kind of maybe help construct an evidence list that helps kind of reassure them that they've had the appropriate workup and they understand their symptoms are likely majority neuroplastic. Um, Working a little bit together to understand what cognitive factors, meaning kind of the stories we tell ourselves, might be kind of putting a danger tag on the symptoms or stirring up painful emotions and nervous system arousal. Understanding what behavioral factors, like the actions we do or don't engage in, might be impacted by by the pain and by our appraisals of the pain, and how that might look like kind of what we call a fear avoidance cycle that's playing out for them. And then once we kind of have that understanding together, reach kind of a shared conceptualization between the provider and the patient of what's going on here, um, then you really get to start the active intervention. And that really, in this treatment, it all runs through an exercise called somatic tracking. Somatic tracking is where you put all of this new understanding into practice, and then basically all of the treatment changes are expected to follow from the patient practicing somatic tracking.
Hmm. What is somatic tracking? Like
Yeah,
what are you saying or what is a patient doing in somatic tracking?
yeah, that's a great question. I would call it a mindfulness exercise. So aspects of it could feel familiar to folks who've done a little bit of mindfulness before. like a mindful body scan, for example. You go inside, and the kind of core things that make it a somatic track are that you go inside your body with your attention and you turn your kind of internal gaze towards the symptom. Uh, the first thing is working on getting that gaze to be a mindful, neutral, calm, curious, willing gaze or stance towards the symptom. This is actually a huge ask. Most people do not like whatever chronic symptom has been plaguing them and altering their life. It's often extremely viscerally unpleasant, and they often tend to either kind of run away, hide, distract from it, or maybe power towards it, white knuckle through it, try to prove they're stronger than it, both of which are entirely understandable. Uh, but to do pain reprocessing therapy and to really somatic track with the pain, you have to find a middle path where you're basically sitting next to it and allowing it to be as it is in that moment. Um, and then the second kind of key thing you do once you get that gaze or that stance right, is you have to deliver messages of safety to yourself. And they have to be believable messages of safety, kind of a Pollyanna-ish, I'm going to wake up tomorrow and never feel this again, is not going to feel believable. And so these messages of safety, I often put in quite a bit of work with the patients to understand what are their stories of danger about the symptoms and what would a kind of compelling, believable, helpful message of safety look like for them. So that can be a very general, I am safe right now. This pain is an error signal that my brain kind of accidentally learned along the way, but nothing is really wrong at that spot in my body. That's an example of maybe a very general message of safety, but it can get a lot more specific than that for the patient. And then the last thing with somatic tracking is really just the expectation of what it is you're doing and what the outcome should be, because it is not a pain relief exercise. Somatic tracking is not something the patient does to get their pain to go from a 5 out of 10 down to a 2 out of 10 in that moment. You actually have to practice it in a sort of symptom or outcome agnostic way, where it's okay whether the pain itself goes up, down, or stays the same when you practice it and afterwards. And your job is to get the fear down, to get the nervous system calm while the symptom is present. That's the new pairing in the brain. Pain present, nervous system calm, that you are giving your brain kind of a practice repetition at this pairing each time you do somatic tracking. And over dozens and dozens of repetitions, your brain will eventually start to pair those things together, and that will remove some of the fuel sources that have been maintaining the chronic pain condition. So it's not a symptom relief exercise, it's a fear relief exercise that over weeks and months of practice can eventually allow the symptoms to start to peter out and resolve as well.
Is this always for physical pain, or can you do this with like emotional pain?
Oh, what a great question. I've definitely had patients who really wanted to play around with it a little bit and aim it towards anxiety, especially when anxiety has physical symptoms in the body, which is very common. And I think if they're really aiming it at a somatic sensation, something they feel in their body from anxiety, especially if maybe they have a background of a little bit of health anxiety and maybe over interpreting some like a tense chest from anxiety as like, oh, there's something wrong, then aiming it at that sort of somatic sensation can be helpful for them. Uh, but I would say, in terms of emotion more broadly and painful emotions more broadly, similar principles of kind of mindful observation and acceptance of those emotions can be really helpful. I wouldn't necessarily go to somatic tracking as the format for that. It's formatted a little bit for uh, kind of chronic somatic sensations in the body. I would say, there's a whole host of other techniques, especially in kind of the somatic experiencing therapies and also the kind of I'm sorry about that. The third wave cognitive behavioral therapies, acceptance and commitment therapy, and dialectical behavioral therapy have a lot to offer in terms of how to practice being present with emotions and not seeking to act on them.
Got it. And does pain have to be, does the tissue damage have to not be happening? Like for PRT to work? Like, does it need to be only central sensitization that is going on, or can you still have a physical pain that is happening that is going to be chronic? Like, let's say you have, even like a GI pain, like your gut, and you're not able to process food very well. And so you have stomach aches and you eat. But like, can you still do the PRT if that symptom is recurring physically?
Yeah, that's a great question. Because I think there are a few different layers here. I think the answer is PRT can apply to a variety of kind of nuanced spots in the middle.
Mhm.
So, one end of the spectrum is something that we'd call completely acute pain and structural pain, right? You put your hand on a hot stove and it's burning your flesh. That pain is a useful danger signal in the moment saying there's tissue damage happening. Get your hand off of there, right? You sprain your ankle going on a jog. Same thing. It sends a lot, your immune system sends a lot of inflammation to the site to say, hey, take your weight off it, let it heal. So those are very useful in the moment, acute structural danger signals. And then the other extreme is something that's almost purely central sensitization, something where maybe there never even was a substantial injury to that spot in the body. And that might be something that we describe. And some of these things still may have complicated factors underneath them, autoimmune things, things we're learning about, but something that's often diagnosed more like a fibromyalgia is something that didn't necessarily have a big injury or illness process to start the pain. Um, and so something like that may seem like the most obvious use case for PRT, but there's actually a lot of space in the middle where PRT can be helpful. And it's really up to the patient, their other healthcare providers, kind of discussing it with them as well as with the PRT clinician to determine if it's an appropriate target. Some common examples, some of it is when there was a major injury. There was time to recover. There was maybe a surgery if it was appropriate, uh, and things have had time to heal. That doesn't mean they've healed exactly how they were before. There may be scar tissue. There may be some changes from what the body has been through. And so you might think of that as still a structural basis for some ongoing pain. But also, the surgeon may know that the outcome studies say, well, patients who've healed this way, some of them are pain-free and some are not. And the surgery wasn't necessarily different. The imaging doesn't look different. So what is leading some patients having chronic pain, but not others? And so often the difference is neuroplastic, even though there are structural things that changed from the injury, from the surgery, whatever it might be. There's also physical things that happen because the body and the brain believe there's danger in a certain spot. And so you kind of gave an example with gastrointestinal issues, and I think there's some other useful examples that kind of show this. Inflammation is a response directed by the immune system based on the brain's appraisal of danger. And so the brain can be sending inflammation to a spot in the body, which does then cause pain for structural reasons. There's inflammation there. Uh, and also, it could be a misinformed uh, decision on the brain's part to send inflammation to that point in the body if in fact nothing is structurally wrong and needing attention or needing more time to heal. Similarly, muscle guarding, where people kind of overly tense and brace certain muscle groups around a joint or a spot in the body that they expect to be weak, then causes a lot of chronic kind of muscle tension, which can cause pain in its own right. So again, you have this physical or structural intermediary that is driving some of the pain, but the reason that it keeps on happening at that spot in the body is no longer because of the original structural injury. It's some kind of maladaptation in which we're overly guarding and tensing our muscles, or it's a misattribution by the brain that believes we still need inflammation there. That kind of perpetuates that process. And so PRT is still very appropriate in cases like that. And certainly gastrointestinal patients also have versions of that can happen with things like irritable bowel syndrome, for example.
It's so interesting because, and my background in Ayurvedic medicine, so Ayurvedic medicine will note that things can go wrong because they can be high, they can be low, or they can be what's called vishama, or essentially means loss of intelligence. So it's
Mm,
not, it's not like an immunodeficiency, and it's not like immune overactivation. It's kind of like wrong intelligence. And so what I'm hearing you talk quite a bit about is how do you reconstitute the intelligence of the neuroimmune axis? How do you reconstitute the intelligence so that when you slam your finger in a door, you can say, "Oh gosh, my finger's in the door. I don't need, this is not the time for PRT to leave my finger in the door and come to terms with the fact it will always be there and just sit here and,
right.
but be able to be proactive about it. And then on another, in another way, in another scenario or situation, to be able to recognize that my brain now is not helping me. Um, and my finger is not in the door, but my brain is sending signals. And so we need to reconstitute the intelligence.
That's a wonderful way to describe it. Yeah, I really appreciate you synthesizing it that way.
So that's what I'm hearing you say. So like, what about something like phantom pain? Because, phantom pain is like, okay, a limb has,
Mhm.
there's been, a diabetic ulcer that's led to gangrene or infection, and now a foot has been removed. And, people will often have pain in the foot, perceived as in the foot. And, we will talk about how nerves piggyback on each other so that when some nerves are triggered, we feel like the foot is there, or like there'll be an itch on a foot that is no longer present that cannot be scratched. Is that something that PRT, like, is that considered
I
now?
would say it's very appropriate for PRT. I'm sure they should do more studies to demonstrate that, given that, again, it's a relatively new field. But one of the reasons I would say it's such a strong indicator is like number one, it matches a very clear thing of we know there's not a structural issue at the site in the body, because in this case, there is not even a piece of the body there to have a structural issue. Another one is that a lot of kind of what they call the pain neuroscience education that PRT is based on and built off of is from sort of a hodgepodge of different studies that taught us how pain works in the body and the brain. And studies on, amputees having phantom limb pain are some of the foundational studies that demonstrated concepts of kind of neuroplastic pain and how important the predictive processing that the brain is doing is to whether a signal is received and whether a signal is interpreted as a pain signal and where it's perceived to be in the body. So yes, I think that's an excellent example.
And have you worked with, or do you know anyone who's worked with patients with mast cell activation syndrome, which is really, again, that erroneous immune response? So the way I describe mast cell activation syndrome to patients, for those who are listening and wondering what that might be, although I think our audience is pretty savvy to MCAS, um, but I think if you're standing on a street corner and you're holding the hand of a small child and a speedy Ferrari comes blowing through, it's natural to say, "Oh, step back and apply a little bit of pressure to the child's hand." But in mast cell activation, it's sort of like you're standing on the corner, you see the Ferrari, you perceive the potential threat, and then you throw the child back 20 feet.
Mhm.
And, it's like the perception is clear and the intention is good, but the execution is messy, and out of proportion for the threat. Um, and I'm just curious, that is a centralization of sorts because it is that core of neuroimmune access again. And so I'm curious if you've worked with those patients or know anyone who has, or think that this might be helpful for these folks.
Yeah, that's a really good question. And I can definitely see the connection you're drawing there where the brain's kind of overactive threat assessment is causing it to do something that it believes to be self-protective, but is actually a maladaptive response in the moment, and it's sustaining the issue. Um, I have actually worked with a few patients. Uh,
Oh.
they did not come initially because of MCAS, but they came in most cases because of long COVID or kind of post-COVID sequela. And they sort of had enough insight to say, like, I think there's a whole host of factors going on in my body and brain keeping me stuck in these symptoms. And several of them had the MCAS diagnosis. And, I kind of worked my way in slowly with those patients to get their understanding of the full picture and what might be appropriate targets for pain reprocessing therapy. And in some cases, we did identify MCAS for that and kind of gave them a PRT-driven approach to use somatic tracking towards their kind of immune over responsiveness. Um, and I have seen some traction and some progress with that. It can also be a complicated one. The body can go to really extreme measures really quickly once it's sensitized in that way. So it can be a slow process as well, but I would say a very worthy target.
Fascinating. Really fascinating. Um, so I'm going to take a quick break because I just want to say thanks to all of our listeners. We've had such great feedback that listeners love our show, and we're thrilled to continue making episodes. And this is where I say that if you are interested in furthering and supporting our mission of having Neuroveda be this clinic that offers these services, one easy way to support us is through our Fullscript accounts. So these companies, Fullscript vets their brands for high quality supplements and takes good care in their shipping. If you use supplements through Fullscript with our account, you can go to the neurovedahealth.com website to our store page to sign up with Fullscript to support us and our larger mission. We do give everybody a 15% discount across the board because we all need some help in this world. And be sure to rate and review this podcast and share it with your friends. That's the end of my teeny tiny commercial. Let's get back to the good stuff here. Okay, so all right, so let's keep going with PRT. So with what we can see is mast cell might be a worthy target, might be something that folks can give a shot. Talk to us a little bit about, we've talked about that somatic tracking. So in these kind of 6 to 10 direct treatment sessions, we've got a couple of sessions about education and the method, and then this somatic tracking piece. And how do things unfold from there?
Yeah, so this is definitely some kind of personal clinical preference here, but I tend to send folks out after a handful of sessions with kind of a somewhat longer, more in-depth, audio recorded guided version of somatic tracking that has a lot of their own messages of safety that we've kind of worked on embedded into that script for them. So they're really hearing kind of their own language that they workshopped to reframe some of the danger stories they've been dealing with. Uh, and so at that point, I usually see patients about once every 4 weeks for a few more sessions, because as we've kind of been saying, that somatic tracking practice is the real intervention. And so once we've debuted that, we're doing kind of this like flipped classroom model where the real work is happening outside of session. And then our 55-minute session is kind of this little tune-up consultation, maybe some little bits of education to progress it. And so I have folks start out with kind of this longer, more in-depth practice. After about a month of practicing with that, we'll kind of review how they're doing, consult a little bit, and then I'll usually teach them a little bit of a formula to do much briefer, kind of 30-second to 2-minute self-guided somatic track exercises. And then they can start to insert those a lot more easily, kind of all across their day and their week, kind of a lot easier to bring it into the moment and do it whenever you can get a chance. And I'll give folks about a month with that. And then the last thing I'll do when they come back after that is teach them a little bit about the neuropsychology of attention and how kind of our frontal lobe is triaging our attention between all different, priorities and things it can attend to, and how chronic pain has kind of hacked that process a little bit. And we need to start giving it different input and different feedback. And we'll talk about how they've already done some of that through somatic tracking, but what it looks like to really cultivate disinterest in this old, unhelpful signal that their brain has been sending them. How do you really give that feedback to your brain so that it really takes the hint? And often people kind of drop off a session or two after that. They maybe have a check-in to make sure things are on track, but they're usually doing really well and really confident in where this is headed at that point.
Amazing. Amazing. And so do patients ever come back for kind of tune-ups? Like, is it the kind of thing like a year later, you're like, maybe people slip back in, or with something like long COVID, you can have another viral hit and then symptoms resume. Do people come back in?
Yeah, that's a great question. I would say it does happen. It's surprisingly rare.
Uh-huh.
Probably fewer than 5% of the patients might reappear for a tune-up at some point. One of the categories of patient that I do this work with that does sometimes have an example like the one you gave is uh, complicated post-concussion patients recovering with kind of a post-concussion syndrome. And so they often do really benefit from, a version of this PRT protocol, and they go off, recovered and live their lives. And then at some point they bump their head again. And sometimes it's a new concussion, and sometimes it's just a really big scare that they might be pretty sure was underneath the threshold for a full concussion, but it still managed to stir up symptoms again. And they're rattled enough that they want kind of a consultation session to talk it through and talk about whether they need to go access any more medical care, whether it's appropriate to use their PRT skills.
Hmm.
And so that's because that's such an easy one to run back into something that resembles the original trigger. That is a population where I do sometimes see some additional checkups, 6 months or a year or two down the line.
Yeah. And so with concussion, though, concussion's particularly interesting, I think, for two reasons. One is that sometimes it's pain, but often it's cognitive processing is the challenge. So how does that work if the challenge is the brain fog or the processing versus just the pain itself, or is PRT kind of focused on the pain of concussion?
Yeah, that's a really good question. Um, yeah, first thing I would just say is I would not really use any PRT techniques within the first 3 months of someone having a concussion.
Mhm.
You want to give a pretty good window to make sure that sort of natural structural recovery is having time and space to happen. Again, not that everyone's concussion recovery needs 3 full months, but plenty do.
Uh-huh.
Um, and so it's somewhere, and given when people kind of get referred because they're starting to feel stuck, it's often past 6 months before I see somebody. Um, and so by that point, there are plenty of times where cognitive processing is still an issue. But I have a lot more confidence by that point that the cognitive processing slowdown is no longer a primary structural issue, but is likely secondary to the fact that their brain is in fight or flight mode far too much of the time.
Hmm.
It's exhausted. It's maybe still straining to deal with pain, headache pain, vestibular dysfunction, dizziness and balance issues. Um, it's maybe still having kind of fatigue crashes secondary to all of this. And so to me, the kind of cognitive processing slowdown at that point is a secondary symptom where if we can go after the things that are actually taxing the brain so much right now and sending it into sympathetic nervous system mode so much of the time, we often see the cognitive processing slowdown start to resolve. So it's never a direct target, but it's a reasonable secondary symptom to expect improvement in.
Fascinating. God, this is so fascinating. Really fun conversation. Thank you.
Hmm.
And so what are the other, how does PRT dovetail with some of the other therapies? Like certainly, concussion's a perfect kind of parlay into a larger body of conditions that include both trauma as well as, physical symptoms and how would you use dialectical behavioral therapy or cognitive behavioral therapy, or how do you switch back and forth or decide that a patient is appropriate for PRT now?
Yeah, that's a great question. Uh, I'm a little tempted to answer in two ways, both other therapies within the world of psychology and outside, because I also want to give credit to the non-psychology practitioners who make really great kind of co-treaters in doing PRT work. And I've had good experiences all across the board, but I will particularly say that physical therapy, when the messaging is aligned, when it's a physical therapist who can deliver messaging in a way that lines up with kind of a neuroplastic idea of chronic pain is an incredibly powerful thing to pair with PRT, because a lot of patients have become somewhat deconditioned in their body if they're limiting themselves because of the pain. And they often do want to build up some strength and some confidence in their movement. And if they've also developed maladaptive movement patterns to kind of shield or guard parts of their body, PTs are really well trained to recognize and address that with them. So that's a sort of a classic therapy outside of psychology that pairs really wonderfully. Again, if the messaging is aligned, if the PT means well, but is reinforcing a lot of fear stories, oh, you've got an asymmetry there. Oh, I don't know, your core is a little bit weak right now. And it's kind of reinforcing the idea that the patient can't get out of pain unless they sort of perfect everything in their body to be perfectly symmetric and strong and flexible. Then we could be running into a little bit of an issue. Um, Within psychology, uh, the first thing to recognize is always, is there a treatment that needs to happen before PRT? And the indicator for that is really just how high are the anxiety levels across the board for this person? Is anxiety raging out of control in another domain of their life outside of just being anxious about the pain or the target symptom? And if it is, it's likely that that needs treatment first. Not that you couldn't give a little bit of kind of pain neuroscience education early on to help them understand, like, hey, this is going to be a treatable thing. But if somebody has untreated post-traumatic stress disorder, untreated obsessive compulsive disorder, and untreated eating disorder, those are the kind of things that actually merit full directed treatment before you engage in PRT with that patient. Because PRT relies so heavily on pairing a calm, safe nervous system with the presence of the pain or the target symptom, and someone who has another major factor that's keeping their nervous system constantly keyed up into fight or flight mode is not going to be able to create enough of those successful repetitions in somatic tracking to generate the outcome we're looking for. So
Got
it
it.
is
Yeah.
really important to get something like that direct treatment first, again, whether that's with myself or the person who's going to provide PRT, or whether that's a referral out with instructions for kind of when to come back. Um, Another factor that can be important is if someone has an external factor in their life that is keeping them kind of locked into fight or flight. That could be a really demanding job where they're sort of on call all the time and getting yelled at all the time and their phone's constantly buzzing, and either the job might have to change or their relationship to their job might have to change for them to get down out of kind of constant fight or flight. Similarly, someone kind of currently in a partnership that has domestic violence going on would not be someone who you could reasonably expect to bring their system into a calm, safe state reliably to do this work. Something would have to change in their psychosocial picture for it to be appropriate to have them practice something like this. There are a couple of therapies that can pair really nicely with PRT, kind of go alongside or, before, after, alternate between. One of them, I think, was developed pretty recently in a large part to pair with PRT. It's called EAET, too many acronyms now, Emotional Awareness and Expression Therapy. And so it's really just designed to help patients get in touch with their own emotions and practice really healthy coping habits with those emotions. So they're less likely to kind of build up and somaticize and contribute uh, to chronic pain syndromes. Uh, and then there are also a lot of folks who really like IFS, internal family systems work, as something that can be done before or alongside PRT. So these are really wonderful companion therapies to kind of do the work on the emotions themselves and on the way we understand and respond to our emotions, which PRT relies upon us doing a good enough job of that, but its own protocol doesn't necessarily teach that or practice that.
And so for something like, there are some chronic conditions, like I'm just thinking about like if you're a parent who has a child with cancer, like you're not gonna, that is going to be a continually terrifying event. Or if you're taking care of a parent with dementia, um, who's worsening, those are things that uh, it feels a little bit different than the acute threat of being in a domestic violence relationship. Because you're not going to do anything different except for be with
Mhm.
in a continually sad situation, which sometimes you are as well in a in relationships. But I feel like so I'm just curious, like, what about those kinds of situations where there is a continual stressor that you are going to remain within, that you are powerless to necessarily change, except you just have to be with it. Is that, would that be, how would that be approached?
Sure. I would say it's definitely not a contraindication for doing
Okay.
PRT work. Um, and those are wonderful examples of, as you said, sort of situations beyond our control that do inflict a lot of emotional distress on us. I would say in order to do PRT work under those conditions, it would be important to be coping in as healthy and flexible a way as you can with the stressor that you're living with. And so, your PRT clinician might feel comfortable kind of looking that over with you and doing that work, or they might say, you may want to have another therapist you see before or during this work to really do what you can around kind of your, not to diminish it, but almost like your emotional hygiene around the ongoing stressor in your life,
Okay.
to really be making space for and tolerating what's difficult about that, without having it bleed over so much that it has your system locked into fight or flight, or like locked into deep depression.
Got it. And can you be on medication and do PRT? Like, can you
Yeah,
be on
absolutely.
benzodiazepines or,
I was going to say, you just named a pretty important one there. Uh, Benzodiazepines are always a little bit tricky with any kind of psychotherapy because they are,
yeah.
fast acting anxiety relief. And so they kind of forestall the brain's need to learn how to do that for itself.
Mhm.
So almost any work that I do with anyone in any direction in my practice, if they're on benzodiazepines, we really check how necessary is it and can they wean off it or can they practice certain things without it or on a lower dose because we do want the brain to learn how to regulate anxiety on its own. And we do want them to actually then develop the confidence from watching their brain succeed at that. And
Mhm.
benzodiazepines can make that really hard to establish.
Yep.
But certainly plenty of other medications, SSRIs, SNRIs. Um, People can be on some uh, painkillers while doing this work of various kinds. Certainly, if someone was on an opioid painkiller and part of the goal is not to be on it long term, then you'll be discussing a plan with their prescribing physician about that. But a lot of people have kind of rescue meds if they have something that kind of touches their symptoms for flares, because somatic tracking is not actually meant to be practiced when someone is at a really high flare of their symptom. If someone's at kind of a 7 out of 10 or above symptom intensity, uh, we actually just recommend kind of rest, self-soothing, self-care, any kind of intervention that kind of lets your body endure and get through the flare is appropriate. And then somatic tracking comes back in when you're back to kind of moderate symptom intensity, kind of a 3 out of 10 to 6 out of 10 on a 0 to 10 symptom scale.
I see
So
that so commonly in practice. So many of our patients have seen between 10 and 50 doctors, and a lot of their symptoms have been somaticized by the medical system. Fibromyalgia is a perfect example. Nothing's wrong with you. Nothing is wrong with you. It's all in your head. And so we have patients who may have mitochondrial dysfunction or maybe have, or even somaticized trauma, but there's this impression that you can meditate your way out of it. Um, and so there's been so much gaslighting that has happened for our patients that it's very sometimes, I think, challenging for them to tell the difference. They've been convinced that what they are feeling is doesn't have anything to do with their body. So a pain is only in the mind. And when we find mast cell activation and we start cromolyn sodium, and suddenly there's no GI pain overnight without any meditation or therapy, they can be very surprised or feel betrayed, or, there's a lot of grief there. And then I would say on the flip side, it can be hard for people to want to connect with their bodies because the pain is so intense. And so disassociation is such a common factor that when folks try to meditate or try to listen to their body, the horror or the shame is can be so intense that their nervous system can kind of be regulated until they pay attention. And then they're like, oh
correct.
shit. And so I think it is so fascinating to hear you describe that the core of this therapy is really that twofold piece of having a nervous system that can be calm and curious and look at the symptoms and that somatic tracking piece. So what an interesting development.
Indeed.
It's very cool. It's very cool. So talk to us about how folks can come see you and your thoughts about any other folks. How widespread is this therapy? How do people find this therapy? Is it, we're here in Seattle, but where is it in across the country or across the world?
Yeah, absolutely. So if there are folks who are in Washington State where I'm licensed who want to work with me, there is often a wait list, but it is doable. Um, and they can reach out via my website, Dr. Aaron Parker, Dr. Aaron, AaronParker.com, to get on that wait list. And then really the broader place to look is painreprocessingtherapy.com is the core website for PRT. And they maintain a directory of practitioners on there who have been through the training, done the full continuing education, and been certified and doing pain reprocessing therapy. And there has been an explosion of new providers getting this training over the last couple of years. So I don't think we're nearly sort of saturated with all of the providers who might want doing this work, but we're definitely getting a step closer. And between folks who might be located near where you live, folks who have what we call, at least for psychologists, licensed clinical psychologists, who have a PsyPact license, which is an agreement to practice across the kind of 38 to 40 state lines right now, with more coming, who can deliver telehealth to anyone else in a PsyPact state. Um, and then some folks, including some from kind of like the core uh, kind of pain therapy centers in LA who train people on this stuff. Some of those folks also deliver this through a coaching modality, which sort of gets around the state license requirements and, of course, has to be private pay in that case. So there are a variety of ways to access it. And that directory of practitioners link right on the Pain Reprocessing Therapy homepage is
Oh,
definitely the place
fascinating.
to start a search.
And so you're going to find a range of licensure underneath this heading. So it's the same training if you're a medical doctor, if you're psychology or psychologist with a PhD, or if you're a mental health therapist or coach. Is that right?
That's mostly right. There definitely are a variety of folks who get this training under different uh, healthcare professions. The one that can be a little different is if you are a physician or another kind of primary medical provider. I think there is also a different training pathway to get training in the evaluation side of this, to be
Got it.
someone patients might go to, not necessarily for the treatment, but to have you kind of review all of their findings, labs, imaging, all of that stuff and help draw the picture of, does this seem to be neuroplastic enough that it's inappropriate for you to go down the PRT pathway with this?
Got it.
And so there is kind of more physician and primary provider specific training on that. And then yes, a whole host of providers under different disciplines can now do the PRT training and kind of deliver a version of PRT.
Great. Great. Fantastic. Aaron, any last thoughts before we finish? Anything I haven't asked or you'd like to have our listeners know?
Oh, maybe just a quick last thought that I think it's pretty exciting where the research side of this is
Oh, yeah.
going. And so we'll
That's a great
all learn
last
a
thought.
lot more over the next 5, 10 years about all of this because they published some great research about uh, maintaining the gains after PRT, which has been fairly promising so far. They've got some great research coming out about the mechanisms in the brain that correspond to chronic pain and how they're changed in the brains of patients who've done PRT afterwards, which is fascinating to see. And then they're also starting to work their way out in kind of giving this full uh, treatment trials towards different conditions. And so they started with back pain because it's such a common and classic one. But right now they're in the middle of doing big research trials for migraine, which will be a fascinating one to see. And in the meantime, a lot of providers, provided that it's clear the condition is neuroplastic, are willing to aim at outside of that, right? I commonly work with post-concussion. I work with a lot of chronic vestibular symptom patients. Obviously, gastrointestinal can also apply here. So I think we're going to see an explosion of fascinating research on where this can apply and how helpful it can be in the years to come.
Amazing. Amazing. We'll definitely keep our eyes out. Um, so thank you. This has been super insightful.
Yeah, thank you so much. It was really wonderful to be on here and chat about all of this with you.
Oh, it's so great. I mean, this is so much the core, and anyway, I could go on and on, but I think you've captured it really well. What we need to know about PRT, pain reprocessing therapy. With you, Dr. Aaron Parker, DrAaronParker.com is how folks can find you. And we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Neuroveda Podcast for complex health. We will see you next time.